Okay, so my name is Andrea Klein, and I'm with Breathe with MD Inc. And so we're going to cover an important topic for our community, anesthesia with neuromuscular breathing weakness. And this particular portion is going to focus on the pediatric perspective. So always we have a disclaimer. Not that you would, but I want to point out, don't use what we discuss here today as a substitute for medical care. And for medical care or advice related to breathing muscle weakness, please seek the care of a clinician who specializes in the breathing issues of those with neuromuscular disease. And today our discussion is with Dr. Oren Kupfer. He's an inpatient medical director with the Breathing Institute of Children's Hospital, Colorado. His specialties are pulmonology, pediatric, and pediatrics. And I will go ahead and introduce him now and have him share a little bit more about himself before we dive into community members' questions.
Well, thanks for having me. I'm really excited to talk with you and to talk about respiratory issues that can arise in our patients as they approach anesthesia. By way of introduction, as was said, I'm a pediatric pulmonologist. I'm in Denver, Colorado at Children's Hospital, Colorado, and I've been taking care of kids and young adults with neuromuscular disease for about the last decade or so. It's really an area of focus of mine that I really enjoy, and I really dearly love this population and would love your feedback at the end of this or at some other point on what we can do to make life even better for you.
Great, I appreciate that. Your specialty is very, very much so needed in our community. Okay, so we'll go ahead and just start with our community members' questions. And the first question that we have is, what is the most important information to provide the anesthesiologist other than telling them that the individual has a neuromuscular disease? And really, are there other individuals that we should be informing about this patient's condition?
Yeah, so whenever possible, and those who have a specific diagnosis, it's important to share the name of the diagnosis or the gene, because there are some disorders that are associated with specific risks of anesthesia. So for instance, Duchenne muscular dystrophy is associated with the risk of hyperkalemia and cardiac arrest and rhabdomyolysis, where others are not. RYR1 myopathy, for instance, is associated very closely with malignant hyperthermia. And other disorders are certainly associated with anesthesia effects. And then there are others that are not. And so it's important, if you have a specific diagnosis, to share that with the anesthesiologist. The other things that are important to share with your anesthesiologist are, what is your baseline respiratory support? Do you use non-invasive ventilation with sleep intermittently during the day and with sleep? And then what do you use for airway clearance, for cough clearance? Because that will play a role in how you're taken care of in the operating room and immediately afterward.
Okay. So do you have any tips of how we would go about doing this? Is this the notifying these individuals of these specific details? Would this be something that's done pretty far in advance, or the day we roll up for the procedure, we let this be known?
Yeah, ideally it would be done in advance. And I'm speaking for children's hospitals now. Most children's hospitals will have some sort of way of notifying the anesthesiologist ahead of time, for days to weeks in advance, depending on how far out the surgery is scheduled. And in Colorado, we have what's called a high-risk preoperative clinic with an anesthesiologist, with an appointment with an anesthesiologist to go over what your risk factors might be. That's not specific to muscular dystrophies, that's for anybody with medical complexity, but I like to have all of my patients go through that process so that they meet an anesthesiologist, and it may not be the anesthesiologist in the operating room the day of the surgery, but to meet an anesthesiologist, they document the certain factors that you have that that make you different from other patients and what your needs will be. And I also write in my notes what I think those factors are. So a lot of pre-operative communication is very important. That's not often the practice for the surgeons. If you're seeing someone, for preoperative spinal fusion or something smaller perhaps than that, the surgeons are not always in the practice of sending patients to anesthesiology. So I advocate for patients and families to advocate for themselves and say, hey, this is concerning to me. My pulmonologist wants me to see an anesthesiologist beforehand. Do you have a process for that? How can we make that happen? And then my role in that is to always have documentation that I give to my patients that says, this is your respiratory care. These are your BiPAP or ventilator settings. This is how I think things should go.
Okay, awesome. So just overall, what are the respiratory risks that should be considered for any procedure involving anesthesia?
Yeah, so I like to break these down into preoperative risks, intraoperative risks, and postoperative risks. So preoperatively, we want patients to be as healthy as possible. And many anesthesiologists or surgeons will delay cases if someone has had a respiratory infection in the last 6 weeks prior to surgery. So having said that, the idea is to stay as healthy as possible before surgery. In patients, for instance, who use their cough devices intermittently, I say, okay, the month before a surgery is really the time where you need to be focusing on this and do some prophylactic care, right? So use your cough assist every day, no matter what. I know it's a pain in the butt, but right now we really need to focus on that, right? We really need to make sure that is happening so that you go into surgery as healthy as possible.
And
Intraoperatively, there are risks, as we talked about a little bit, for hyperthermia or malignant hyperthermia and hyperkalemia, cardiac arrest. And so that's where talking to the anesthesiologist preoperatively is important. In surgery, definitely depending on how long the surgery is and what the nature of the surgery is, there's also a risk of hypoventilation. Although our anesthesiologists are very good at keeping an eye on those parameters during surgery. And then after surgery, I think is the real big area where we need to be very precise about what we're doing. And so many anesthesiologists just want to take out the breathing tube and let patients wake up. Well, when you have respiratory muscle weakness, that doesn't work, right? It's just like any other sleep. So if you're asleep, if you're on non-invasive ventilation beforehand, you need to be on that. And then thinking about not just the immediate postoperative time, but the time period recovery in the hospital and then afterward at home, we have to think a lot about airway clearance and about using our BiPAP or non-invasive ventilation devices and prophylactic, again, cough management.
So talk just a little bit more about those types of reactions that individuals can have to anesthesia, the malignant hyperthermia, or like events that tend to sometimes be more common in certain forms of neuromuscular disease than others.
Yeah, so they're more common in dystrophies and myopathies, so problems of the muscle rather than problems of the nerve. Although each disorder has its own unique characteristics. So the medications that we want to avoid are volatile agents, the inhaled anesthetics, as well as the depolarizing agents like succinylcholine. So those are muscle relaxants essentially. And because they have impact on muscle and the muscles are sick or not typical, then we need to avoid using those. So I'm a lumper more than a splitter. So I like to categorize these as if you have a muscle problem, less so a nerve problem. If you have a muscle problem for your neuromuscular disease, then you really should avoid succinylcholine and the inhaled depolarizing agents. IV anesthesia is usually fine.
preferred
Right.
above any inhaled. Okay.
Right.
And
So
then,
most of our patients end up with IV only anesthesia.
okay. And are there other medications that should be avoided before, during, and after surgery? Things that have a sedating or respiratory drive suppression type effect?
Yes. So the most common medications used post-operatively for pain, at least initially, are opiates. And so things like morphine and the like. And those cause shallower breathing and slower breathing. And someone who already has shallow breathing from respiratory muscle weakness, this can be a real problem. I think I don't want to overstate that, because I think pain management is very important in the post-operative period. And so we just have to be careful with that. So my practice is to be relatively conservative and say, you need the pain management that you need. You deserve that. You have had a painful procedure. My job along with you is to help you breathe through that. So that might be using your non-invasive ventilation while quote unquote awake, or during daytime, even if you're a little bit groggy with your pain medicines. There are other medications that we use as adjunctive therapies, like Valium or Versed, the benzodiazepines, that can also cause respiratory depression. Those are often used when muscle is cut, because muscle tends to contract and get very inflamed when it's cut. So for things like spine fusions and hip surgeries, we tend to use some Valium. And so Valium plus the opiates together can cause respiratory depression. So then we just need to keep an eye on that. Cough is also suppressed by those medications, so we have to keep a close eye on cough management. And then there are other medications depending on what you're taking. But so the other common pain medications are NSAIDs, like Toradol, ibuprofen. Those we have to be careful with if someone is also on blood pressure reducing medicines, especially ACE inhibitors, for if they have a cardiomyopathy, because the combination of those two can cause some kidney injuries. So the NSAIDs fall into the category of pain management as well. So we just have to be really mindful of all the medications we're taking.
Okay. And I think we really probably already covered this. Is there a standard of care for types of sedation, such as when to use inhaled versus IV sedation, or local versus general?
Yeah. So the national leadership groups for anesthesiologists have guidelines for anesthesia and neuromuscular disease. And so they should be well versed in those. And so that guides a lot of anesthesia practice. Generally speaking, I would say we should not be using inhaled anesthesia. Sorry, I'm looking at some of my notes here that I took when you sent me some leading questions. And if there's an opportunity to use local anesthesia, that would be preferred. Oftentimes for bigger procedures, that's not sufficient. I've seen in some cases spinal blocks or nerve blocks used, and that can be very powerful in limiting the general anesthesia, and also frankly for post-operative pain management, that can be really helpful. Yeah, so asking your anesthesiologist to be maybe a little bit creative is a good idea, but if they say, you know what, I'm really not comfortable with that, okay. They also have to be comfortable with how to manage these things.
Okay. So this is another one that we find a lot in the community, in particular in our support group, is people ask what personal equipment they should take along for the procedure, for the hospitalization.
Yeah, so the easy answer is all of it.
Yeah.
But I'm going to stick to the respiratory equipment, but I recognize that there's other equipment as well that should be brought. seating, bathing, seating, toileting, all those things need to be brought as well. So I recognize how much we're asking people to move their home to the hospital. In terms of respiratory equipment, if you have a BiPAP machine or a ventilator, absolutely bring that to the hospital. If you have a cough assist machine, bring that to the hospital. If for some reason you also have a vest or any kind of airway clearance device that's not a cough assist, bring that as well. And the reason for that is twofold. One, we're going to use those after surgery to help you stay healthy, to avoid postoperative respiratory issues. The second is the hospital is unlikely to use your machines immediately after surgery. They're going to want to use their own. But having your devices there for them to look at and to see the settings on as a starting point for them is vitally important. Otherwise, they're essentially making up the settings, and that's not sufficient. If you have a pulmonologist, ask them, if they don't already do it as a matter of practice, ask them to write down the settings from your devices so that you can bring that to the hospital as well. Sometimes it helps to have the doctor's signature on a piece of paper that says, these are my settings, especially if you're having surgery in an institution where your pulmonologist is not affiliated.
That's a great tip. So, any tips to avoid complications during and after procedures with anesthesia?
Yeah. Cough assist, cough assist, cough assist, cough assist, cough assist.
In preparation. Yes.
That is absolutely our most important tool, along with non-invasive ventilation. So if you already use non-invasive ventilation at home on a regular basis, you should absolutely be on it after surgery. And we should be prophylactically doing cough assist several times a day. Again, because you're even more immobilized than usual, and you're receiving pain medications, your breathing drive may be even just slightly reduced, and that's enough to lead to possible problems. So I'd rather be very aggressive and just prevent any issues.
So possible problems being like an increase in secretions that maybe one didn't have before the procedure.
Right. The other thing I didn't talk about with opiates especially is that they can slow down the gut. So the gut doesn't move as quickly under the influence of opiates. People can get constipated. That can cause nausea, that can cause abdominal discomfort, and it can push up on the diaphragm and cause some breathing difficulty. So pushing back on that with BiPAP is helpful. And some of my patients use mouthpiece ventilation. I think very few institutions are comfortable with that on an inpatient setting. So introducing that to them would be very helpful as well. So if you can do sip and puff or mouthpiece ventilation during the day instead of a nasal device or full face device, that could be helpful as well. The thing that that is very different about neuromuscular disease in the post-operative period is that we have to think about low oxygen very differently. A lot of people have intermittently low oxygen after anesthesia for a number of reasons. And if they don't have neuromuscular disease, we just give them a little bit of oxygen. We say, you're probably fine. We'll get you sitting up and moving. That's not how we should behave with neuromuscular disease. Low oxygen cannot be responded to with just adding some oxygen by nasal cannula or by mask. We have to do cough assist and we have to use non-invasive ventilation. So I would be super aggressive about that.
So one of the other questions was, are there different options for intubation and ones that are more well suited to those with neuromuscular conditions?
We can use, depending on the length of the surgery, we can use just mask ventilation. So just the anesthesiologist holding a mask over the nose and mouth and providing ventilation that way. For any procedure longer than, I don't know a cutoff, but anything that might require more than just a few minutes of anesthesia, I think I would not want to do that because it's an unstable airway. There's another device called the laryngeal mask airway that is like a breathing tube, but sits on top of the vocal cords with kind of a mini face mask, just sits on top of the vocal cords and allows the anesthesiologist to ventilate and oxygenate. That still requires general anesthesia because, as you can imagine, something going into the back of your throat and down to the level of the vocal cords is quite uncomfortable. So I don't know that that has a whole lot of benefit in general anesthesia over a breathing tube. Again, that would also be for relatively limited time limited procedures. But again, the risks of general anesthesia still apply in that scenario.
Mhm. And then we had someone that was asking about neck contractures and limited mouth opening, which is something that can occur in some of the congenital forms of neuromuscular disease. And how does that get accommodated during intubation?
Yeah, so that's a very challenging obstacle to overcome. I think that's one of the big reasons to be seeing anesthesia beforehand, to talk about how they might manage those things. You know, they'll examine you, they'll see how far can you open your mouth, how far can you extend your neck, and they formulate a plan from there. Anesthesiologists have a number of tools, including fiber optic intubation, so they can use a scope, either their manual laryngoscope that with a camera on it, so they can see better than just from the outside, or we can actually intubate over a bronchoscope, so a fiber optic camera that lets us directly visualize the airway. It can be quite challenging, especially with people with limited mouth opening, plus a larger tongue, plus neck contractures, can be very challenging. For my very impacted patients, usually young adults or adults with like Duchenne muscular dystrophy or spinal muscular atrophy, I have a frank conversation about, listen, this is a challenge, and I think you have to be ready for some of the consequences that may happen from a difficult intubation. We may be able to get the tube in, but that doesn't guarantee getting the tube out, right? So if we're thinking about a surgery, one of the things we have to think about is, what am I willing to accept as a consequence of this surgery, right? Am I willing to have a long hospitalization? Am I willing to think about a tracheostomy even? Because sometimes, although with good planning, it's relatively rare, but sometimes that is the outcome of having a surgery that's completely unrelated to breathing. So that endotracheal tube is very difficult to remove and support your breathing. So it's something that I have a conversation with many of my patients about, especially as they get on in age.
Yeah, we actually are seeing that as more common than not to occur in the older adult population. So
it's just a conversation we have to have, right? If this is an important surgery, that's fine, but we have to really explore all the potential outcomes that may happen from this.
Definitely. Another question was, how is breathing support managed during oral surgery? This one has come up quite a few times. I know some patients have been told by their pulmonologist, just go in and wear your BiPAP during that tooth extraction, but your mouth is open. So
yeah, I struggle with this one. This is a challenging question. I think a lot of it depends on how impacted the patient is, how impacted the child or adult is. I don't know how well using BiPAP with an open mouth is, but if you're just having local anesthesia for a tooth extraction, then that can be done relatively quickly, and I think nasal support might be sufficient. I would still prefer that procedure be done in a hospital type setting with an anesthesiologist rather than just the dentist running the anesthesia while doing the procedure. So I think preparation there and being overly assertive and a little overprotective might actually be the right thing to do. Where you say, yeah, I'm just having a tooth extraction, but I have all this respiratory stuff that really needs close attention. Can we please just do this, not in the clinic, but in the hospital-based setting? And I think that that's probably the most important thing to do for dental extractions. If there's no way to support breathing non-invasively during a dental procedure, then it's back to general anesthesia and all the things we've talked about before.
Mhm. Okay. So we touched on a little bit about extubation and challenges with that. Is there a neuromuscular disease protocol that we typically follow for that, or that we can share in advance?
I wish there were. Institutions have written their own neuromuscular protocols, but there's no real single protocol. I think the more important thing is to think about, as a group with your doctors and the inpatient team, what can go wrong or what can be better achieved while intubated than extubated. So the things I think of, and I practice at a mile high, so my parameters are a little bit different, but let's say we're at sea level. I would, before extubation, I would want a chest x-ray to make sure that there's nothing but air in the chest where it's supposed to be, right? So no atelectasis or lung collapse, certainly no pneumonia. And then I would want to see that the chest is as well inflated as possible, okay, given the underlying disease. I'd also want to make sure, especially in our patients with some component of heart disease, that there's no pulmonary edema, right? And that just speaks to how much are we going to have to clear out of the airways. At sea level, I would hope that oxygen requirements would be at room air or just above, maybe 25% oxygen. As a sign of we're doing pretty darn well breathing wise. And then the last thing is secretion burden. How often are we having to suction that endotracheal tube? How often are we having to do cough assist or other maneuvers to get mucus out? And that's a bit of a tricky question, because having a tube in the airway can lead to the creation of more secretions in and of itself. So if those secretions are easy to remove, then it may be okay to take out the tube. So the idea is that breathing is supported really, really well invasively, and we're in a place clinically where we can also manage it non-invasively.
So this question also included, should we have an extubation plan in writing? Should we have anything at all in writing, I guess, to express our wishes and related to getting extubated as soon as possible, knowing that there are all those other factors that have to be considered?
Yeah, I go both ways. I go both ways on that. Certainly, wishes for like long-term care and outcomes should be discussed beforehand. Absolutely, and written down is even better in a formal document. But the specific like physiological parameters of what the oxygen should be, what the frequency of airway clearance should be, I struggle with being very prescriptive, because sometimes what that does is drives people to get to those markers and then no matter what, take out the breathing tube, instead of saying, well, we've arrived at these markers, how is my patient doing? So I would rather have the discussion before surgery with anesthesia, or if the extubation is going to happen later, potentially even with the ICU doctors, and then have the pulmonologist, whenever possible, consulting as well to be your physician advocate.
Let's see. How do we plan to manage post-operative oxygen saturation levels with non-invasive ventilation?
Yeah. Oh, this is a
On
great
the bit.
question. This is a great question. So I alluded to this a little bit before where, and I write this in all of my notes in the hospital. The response to low oxygen cannot be to add oxygen, right? The problem in neuromuscular disease is I cannot inhale or there's mucus in the way. So if I cannot inhale, that's non-invasive ventilation. You can add oxygen to non-invasive ventilation, fine, but you can't just do oxygen. You have to push the air in. And then you have to cough. You have to get that mucus obstruction out. But even if you're adding oxygen to non-invasive ventilation, if you just keep cranking up the oxygen, you're still missing the point. Your team is still not taking care of what's going on. And so I would say you might need higher pressures on your non-invasive ventilation, right? You may just need more force to get past whatever mucus you have or to overcome the additional respiratory suppression from your pain medications. Yeah, so non-invasive ventilation and cough assist.
Okay. And you kind of touched on some of what I think the answer will be here too, is there a respiratory protocol for that first week after surgery?
So yes and no. Be aggressive is my rule, right? Lots of non-invasive ventilation. So if you only use BiPAP during sleep, well, I may ask that you use it 24/7 for the first day or 2 or 3 and see how we're doing, which can limit like oral intake. I recognize that that's a big challenge. And then slowly wean off during the day. If you have mouthpiece ventilation, using that throughout the day would be exceedingly helpful. And then tons of cough assist. Just stick to prophylactic every 4 hours instead of the usual once a day, even if you're feeling well. And then we can slowly back off.
Or every time you need to cough, which could even be,
Sure.
I know I've had illnesses before where it's literally like every hour I'm having to use that cough assist.
Absolutely. Yeah. I'm thinking in terms of like hospital protocol where I have to order something and then it happens on that schedule, but absolutely use cough assist as often as you need to cough. And what I tell our staff is if your patient is dropping their oxygen saturations, go cough them right away. That's the first thing you do. Some institutions will try to use incentive spirometry, respiratory muscle retraining to take big deep breaths and blow out against pressure. And I don't think that's particularly useful in someone with respiratory muscle weakness. That's just asking them to fatigue. So I would say cough assist. Now in a children's hospital, we are pretty relaxed about families using cough assist for their children, especially if it's their own device. So, if we have an order that says every 4 hours, but the child needs more, families should feel confident in doing more cough assist as well.
Yeah, and from what I hear, often the family is who is more often having to assist with it because there's just not staffing necessarily to support how frequent they're going to need to use it. So family probably needs to be prepared and plan for that in advance to be available to assist with that.
Yeah. That is a great point. I would want families as available as possible. I think it can be sometimes disappointing when you say, well, I came to the hospital, they're supposed to be able to do everything for me, but they can't get the cough assist right at the time I need it. And that's because a whole lot of things are going on in the hospital. So having someone in the room that is only focused on that one child, as in the parent, is super, super critical.
Sure.
And if you're an adult, having someone who can stay with you the whole time in your adult institution would also be helpful.
And then we pretty much covered this too. This is asking what kind of post-op pulmonary care and rehabilitation should we anticipate? Airway clearance, weaning, sitting up more, physical therapy, other things, which are gonna, I'm sure, vary from patient to patient.
Yeah, it is all of those things. So returning back to your baseline level of activity as soon as possible, while still managing pain is the most important thing. I don't want to sound like I'm against pain management at all. I think it's critically important to manage pain because we get shallow breathing and splinting of our breaths that can cause more respiratory issues. So you need adequate pain management, and then you need a friendly pulmonologist to help counter the effects of those pain medicines. Yeah, everything else, I think tons of cough assist, getting back to your baseline. And then what I've started talking about with my parents, and this is my personal experience, is that going into a surgery, especially something big like a spine surgery, takes a lot of mental preparation too. The patients I've seen leave the hospital the soonest are the ones who come in with a positive attitude. The ones who come in saying, yes, I can, I'm ready, and they do the best. I'm a pessimist myself for my own self. And so I struggle with that. So maybe I'm more giving myself a pep talk than anybody else. But I found that having a positive attitude and they're like, yep, I just need to do my cough assist a ton, and I need to wear my BiPAP more than I usually do. Okay, let's go do this. That is crucial.
Yeah, that's one of our biggest challenges, is just getting people to use that cough assist and recognizing that it's not all about using it for the benefit of using it. It's also getting into the habit of
Yes.
using it, and not being in a situation where you need it emergently and you're not used to it, or you don't even remember how to use it. So yeah, there's just a lot of value in getting used to that before you're going to absolutely have to use it for your, basically for your survival and for the best outcome.
Yep.
So any other additional tips or thoughts for a successful outcome with any procedure requiring anesthesia for this age group?
I think what we haven't talked about is all the other medical complexities that our patients might have. The one that comes up with anesthesia the most is probably cardiac. So if you have a cardiac condition or risk for cardiomyopathy or rhythm problems, then at least talking to your cardiologist, if not seeing them for clearance before surgery, is super important as well. Some patients even require cardiac anesthesia if they have a significant cardiomyopathy. And so having that discussion is important. And then making sure that your neuromuscular team, your chronic care team, is aware of what's happening and where it's happening is very important too. We at Children's Colorado are lucky in that most of our patients have their procedures done here. And so we go visit them. We say hello, and we find things that we overlooked. I forgot the bath chair, or my Hoyer lift doesn't work. I brought it and it got damaged on the way. Like, what are all these things? So be in touch with your team so that we can help troubleshoot some of the things that may come up post-operatively for you.
So really having good communication with that care team for planning, during, and post-operatively too, for follow-ups.
Yep.
Probably very important.
Yes.
Okay. Can you think of anything else that we need to cover on this topic?
I don't think so. I think these questions were phenomenal. I'm just looking over the list and I took some notes. The questions about dental procedures, boy, are those challenging ones. Yeah. Those are really tough. And you think it's just a tooth extraction. Well, sometimes that can be the big challenge. So yeah, I think these questions really covered it nicely.
I personally have had issues with the oral surgery, and I had one that it came down to a decision of what was better for me, the risk to my respiratory health or dealing with, in my case, it's a receding gum line around one tooth. And they wanted to do a tissue transplant from the roof of my mouth to this area of gum, which it's not super common, but I know others that have had it. And of course, they're not in my situation. So the thought of having a wound on the roof of my mouth with air constantly, pressures of air flowing through that area at night, that's concerning. But the big red flag for me was the oral surgeon acting very confident, overly confident that, oh, I've worked with high risk patients. There'll be no problem whatsoever to have the procedure in the office. And for me, that was the red flag alert to, I need to get out of here as quickly as possible and either just not do this at all or find someone else who's willing to do this in an inpatient setting, because all too often, at least with the adult population, I know we find that clinicians are overly confident in their ability to care for us. But yeah, that one is, oral surgeries are often neglected because we just don't have confidence in any one clinician who can adequately maintain our airway and not make things go south really quickly.
Yeah, you make a really good point that the quote unquote minor procedure is not minor.
Yeah.
For someone with neuromuscular disease, especially when you're in and around the airway. No procedure is minor. And so you know, people might look at you, they certainly look at me askew when I say, yeah, this kid needs to have their tooth extracted in the hospital. They're like, what are you talking about? It's a tooth extraction. It's like, and you know, and if they look at me sideways after because everything went fine, great. I'm glad everything went fine, but I'd rather be in a safe place. So I guess the message is, if you are concerned that that your condition is not getting the respect it deserves, go somewhere else.
Yeah, definitely. We always have to be an advocate for ourselves or our family member. It's just so important that we speak up for ourselves, even if that means ending a relationship with one clinician and having to start all over again. You know, that may make the difference in a really difficult outcome, horrible outcome, whether we do that or not. So,
yep. And you should not feel bad about that at all. If you got to move on from somebody else, go for it.
Yeah. And clinicians, they're, at least in my experience, they're generally very professional about that. They expect that. That just happens. That's
Right.
just part of practicing medicine, that you will have patients that come and go and move on to other clinicians. So,
absolutely right.
okay. Well, thank you so much again for your time, Dr. Kupfer. This was just very valuable information for us to have. I know our community is going to be very, very thrilled to have this information at their fingertips. So
Awesome. Happy to help.